Excellent. Good afternoon, everybody. I'll be doing the afternoon report today. We'll start off with our chief complaint. 34-year-old male presenting with 10 days of dyspnea. A little bit more about his history. 34-year-old male, HIV, diagnosed in 2015. He's non-adherent with his ART therapy for about 1 year. Also IVDU drug user, meth. The last use was about 3 weeks ago. He's had syphilis in the past that, according to him, has been treated. He's coming in with progressive dyspnea of around 10 days. He says his dyspnea is worse with exertion. It's associated with some dry cough, and he reports occasional fever up to 100.2 Fahrenheit at home for the last month. A little bit about his background. I mentioned HIV, non-adherent on ART therapy, syphilis that was treated in the past, family history, none, social history, MSM, IV drug use, meth. Last use was about 2-3 weeks ago. Former vaping, he stopped 2 years ago. He's non-adherent because of a recent loss of partner and a loss of occupation. For medication, Sturbild from 2015 to 2019, and allergies, none. Does anybody have anything that they would like to ask about this patient before we get to the physical exam?
Any more questions about his history?
Any orthopnea?
No orthopnea.
Any sick contact or any recent travel?
No recent travel, and no recent sick contacts. He's been living alone, and it's during the COVID time, so he didn't really leave his house.
Any specific work exposures to any,
No, he's not. He's currently unemployed.
Okay.
I think Carlos asked in the chat, what's any recent CD4 counts?
He doesn't know his last CD4 count. The last time he went was about 1.5 years ago. According to him, everything was normal at that time.
Any history of any opportunistic infections with the HIV?
No.
So, what
Dyspnea like this.
infection could you specifically ask for in this patient?
Like PCP in the past?
So you want to ask for any history of any AIDS-defining illness, because in a patient with HIV, what's the difference between HIV and AIDS? It's when you have an opportunistic infection like PCP. So history of PCP infection would give this patient the diagnosis of AIDS. So then 2 more questions in the chat. Any recent hospitalization and any history of TB?
No recent hospitalization. You're asking any recent history of TB? No. He said he's never had any sort of lung infections in the past. He said he's never been to the hospital in the past other than for his syphilis.
So for this history of TB, what are other questions you should ask? Somebody might not have history of TB, but they might be at risk for TB. So what questions would you elicit to see if this patient is at risk?
Incarceration.
Good. History of incarceration. Anything else?
No prior history of incarceration.
You could ask for associated symptoms if you're suspecting current TB, like weight loss, night sweats, malaise.
History of constitutional symptoms. Anything else? Any history of if this person lived in a shelter? That's a risk factor. If this patient, where was this patient born? Was the patient born in the US? Patient born somewhere else? Yes, exactly as Carlos said. Has he lived anywhere else? So these are questions which you have to ask for TB. You can't just say, has he had a history of TB or not? You also have to elicit other specific risk factors. Okay, any more questions?
So he's a US-born male. He says, in terms of his sweating, he says sometimes at nights he feels sweaty and no recent weight loss. He says there's no real weight changes, but he has a lack of appetite.
Let's move forward.
Physical exam, his vitals, his temperature was noted to be elevated at 38.2 Celsius, pulse 87, respiratory rate 20, blood pressure 100/67, SpO2 96% on room air. He's not in acute distress. His cardiovascular exam was normal S1, S2, no murmurs, regular rate and rhythm. Respiratory exam was clear, bilateral breath side, no rhonchi, no wheezing, and GI, no abdominal tenderness, and normal bowel sounds. On the skin, we found multiple oval purple plaques and nodules on the trunk and upper extremities that were non-blanching. When we asked him a bit more about these oval plaques and nodules, he said he probably started noticing them about a month ago. And they've kind of stayed consistent in size, fairly large, about 1 to 2 centimeters. Anybody have any questions?
Did you walk him at all to see if his sat dropped when he moved?
No, I didn't. We didn't actively check his saturation, but he was able to walk around for us without any noticeable shortness of breath. We should have done that as well, but we didn't do it in this scenario.
Yeah, it's just an old way we used to diagnose PCP years ago.
Right.
Mantaj asks if we have a picture of skin lesions, which we do, but we'll go through it later. Any other questions about examination? Any other examination or any things you would look for?
Are any of these plaques in his like mucosal surfaces, like in his mouth?
Great question. His mouth was cleared of any of these plaques.
Okay. Great question. Mantaj asks, is there, did you see oral thrush?
No, no oral thrush.
Okay. Any more questions before we move? Anything anybody wants to clarify with the examination? Mantaj asks lymph nodes.
No, no noticeable enlarged lymph nodes. I mainly felt supraclavicular. I didn't feel anything. And under his armpits, I did not feel any enlarged lymph nodes. And also his pubic lymph node area were not enlarged.
All right. So let's move on. Next slide. So that's
Next slide, the pictures of the actual lesions on his body.
Anybody wants to describe them? How would you describe these lesions? They're not maculopapular. That much I can tell you. Take a stab. Who's going to take a stab? Let's see. Michelle.
So they seem papular. They're slightly elevated. Margins are irregular. About 1 to 2 centimeters. Maybe the one on the right side is a little bit bigger, and seem to be bluish purplish in color. But the margins do seem defined, so I can see the transition from normal skin to the lesion.
Yeah. So good job. So purplish, violaceous. To differentiate between a papule and a nodule, you see it's based on size. So this seems slightly larger, so it's probably nodular. I don't remember the exact cutoffs. So a nodular violaceous rash on the patient's back. All right. Let's move forward.
Does anybody want to come up with a problem representation before I go to the next slide?
So who's going to? We can work together. Let's see who's here. Vincent. Let's try. Let's go.
Sure thing. So we have a young 30-year-old male with history of HIV and not accompanied with ART and a history of syphilis, who present with, I believe, a 1-month history of shortness of breath, dry cough, and fever. Physical exam significant for these violaceous plaques on exam. And right, I think that's.
And so he came with respiratory symptoms, right? He came with shortness
of breath.
What was his respiratory exam?
Oh, dyspnea on exertion, respiratory exam. I think I forgot what.
So he was not hypoxic on room air, and how was his lung exam? Did he have? Can you go back to the lung exam, Yoni?
Yeah, so that's what I thought. Yeah, there was no unremarkable respiratory exam, clear lungs, with no wheezing.
So yeah, we know who is our patient. What's his age group? He's a young patient. What's his significant past medical history? You said HIV, possibly AIDS, and he came with what syndrome? He came in with a dyspnea kind of. So pulmonary syndrome with subacute progressive dyspnea, and also on exam seem to have clear lung sounds but seem to be febrile. Anything else anybody would like to add to this problem representation?
Okay, very good. Middle-aged male with HIV/AIDS presents with subacute progressive dyspnea and fever. Found to have multiple oval nodules on trunk and a clear lung exam.
Great. So
Um,
let's take a break there. Let me share my screen now. All right. So we have a patient with HIV or AIDS, most likely AIDS in this case, who's coming in with a pulmonary or a respiratory syndrome. So let's talk about the differential diagnosis for such a patient. So we have a respiratory syndrome or dyspnea in a patient with HIV, most likely AIDS in this case. So how would you have a framework for this patient? Do you have any frameworks for patients presenting with respiratory syndromes or dyspnea? One way I like to differentiate or divide it is you can have parenchymal causes or extra parenchymal causes. And keep in mind, this is a patient with AIDS, but this patient is also as at risk for other causes of respiratory syndrome. So you don't have to box yourself into all infectious or opportunistic infections, but you have to think about the patient broadly because these patients can also have other causes. So let's start with the extra parenchymal because we can come to the infectious and parenchymal causes later. What are extra parenchymal causes of dyspnea?
Pulmonary hypertension.
Good. Pulmonary hypertension.
Heart failure.
Heart failure.
PE.
PE. Good.
Pleural disease.
Fusion. Pleural disease. What else?
Malignancy.
Malignancy, if it causes a pleural effusion, yes. If it's primary lung malignancy, it would probably come under parenchymal, right? Or anything else you would think which would come under extra parenchymal, which would be a malignancy. It would usually manifest as an effusion. Anything else which can cause dyspnea, which doesn't affect the parenchyma of the lung? We talked about. Sorry.
Ascites or liver failure.
That would probably cause effusions.
Fusion. Yeah.
So I see
Diaphragmatic disease.
diaphragmatic disease. Good. I see somebody posted anemia, obesity, scoliosis. Yeah, so all of those. All right. All right, so we have good workup for extra parenchymal causes. Now let's talk about parenchymal causes. Now, since we have a patient with immunosuppression, we can divide these into infectious and non-infectious. Because the infectious differential will be very broad, so let's save that for last and let's talk about non-infectious causes. So what are non-infectious causes? Actually, we forgot one here. Important one which goes with CHF as well is you have
heart disease.
Pericardial disease, yes. Not to forget. All right, back to non-infectious causes. So somebody already said cancer. So what cancers can cause this syndrome? What kind of cancers would affect the parenchyma and cause? Okay, so primary lung cancer, all right.
Disseminated Kaposi.
Good. Disseminated Kaposi.
I would say lymphoma if it's compressing, like.
All right, and by
actually,
go ahead. Who was that?
It's me, Anne. I think that lymphoma will be more likely like non-parenchymal because it will be for the compression.
So yeah, lymphoma can cause parenchymal and non-parenchymal, but in this patient with HIV, is there any particular lymphoma you're worried about?
Just can't remember.
So non-Hodgkin lymphomas, usually primary CNS, but they HIV advanced immunosuppression puts you at risk for non-Hodgkin lymphomas. All right. What else? Did anybody say the more common causes
Like
yeah,
COPD, asthma.
the COPD, asthma. You have to think about the common things, because even though this patient has a red herring with advanced immunosuppression, you have to make sure you don't miss out on your bread and butter causes.
And then, I mean, you want to think about like restrictive lung disease or other inflammatory conditions.
Vascularitis.
Is very important. David, you said something?
Vascularitis.
Vasculitides, yes. In ILD, so let's talk a little bit about ILD. So which particular ILD can you see in patients with advanced HIV or AIDS? Okay, not very important, but just keep in mind lymphoid interstitial pneumonia is usually associated with immunosuppression. So that is one particular ILD which you will think about in these patients. So we talked about COPD, asthma, we talked about malignancies, we talked about primary lung cancer, Kaposi sarcoma, non-Hodgkin's. You can also have metastases, right? Metastases from other primary organs. So those can cause nodular lesions or effusions. One more. So this patient did not take their medicines, but you can have patients who did take medicines, and those medicines can have potential pulmonary toxicity. So you can have medication-induced disease. All right. Anything else? Any other non-infectious cause? Not that I can think of. All right. So let's talk about infectious causes now. But now we'll have to do it systematically, and we have to think about common things common. So what's your most likely differential here amongst infectious causes?
PCP.
PCP, good, but like common things common first, bacterial pneumonia. So bacterial pneumonia are also very, very, I mean, even in patients not who don't have AIDS, who are like patients living with HIV, there is a higher incidence of community acquired pneumonia. So the first thing would be a bacterial pneumonia. And then you can divide those into typical and atypical. We don't need to talk about that today. All right. Second thing, as Francisco said, PCP. What do you want to tell us? Which CD4 count do you use as a cutoff, or like which patients?
Yeah,
200.
200. Yeah.
Good. All right. Any other broad causes? Infectious cause?
Aspergillosis.
Sorry?
Aspergillosis.
Okay, so fungal causes.
Yeah.
We'll talk about those later. Let's talk about other more common causes.
TB.
TB.
TB. All right, good. So TB is very important in these patients, and we, yeah, I see COVID-19. So yeah, we will also make a separate section on viral. So COVID-19. Any other viral causes? What other viral manifestations of AIDS? Yes, Frida said CMV. What is the most common affected organ by CMV in patients with immunosuppression? What's the most?
What's that question?
Retina?
So in patients with CMV, what would you specifically examine? They might have CMV pneumonitis or CMV like manifestations, but
is it retina?
Good, yeah. So you have to look at the retinas to make sure CMV retinitis is not there, because that's usually one of the most common ways of CMV in advanced immunosuppression to present. Any other more common virus? We talked about COVID. What was the virus we thought of before COVID?
RSV?
Flu.
Flu. So common things common first, all right?
And MAC? Are we considering MAC?
Good. So that would go along with TB. So, and MAI, what CD4 count?
50.
Good, yeah, 50. All right. We talked about TB. Anything else? Any other broad group?
I mean, any parasite, but will be more uncommon.
Uncommon, but yeah, parasites are also possible. Which parasites usually affect patients with AIDS? I mean, I'm not talking about pulmonary here, but any parasites in general.
Cryptococcus.
Iridium.
One at a time. Andrew, what were you saying?
Cryptococcus.
Sporidium. Cryptosporidium.
Cryptococcus is a fungus.
No, Cryptosporidium.
True.
So that causes
I
diarrhea.
know Giardia. Giardia can cause diarrhea. It's very
Giardia,
common,
good.
but it's not going to cause.
Strongyloides.
Yeah, excellent. Strongy is very commonly seen in these patients with advanced AIDS, and they can cause both GI and pulmonary manifestations. CNS, what CNS disease is caused in patients with AIDS?
JC.
Cryptococcus.
No, but specifically a parasite.
Oh, parasite. Toxoplasma.
Toxo.
Good. Yes, toxo. So toxo commonly affects the CNS, but can uncommonly also cause a pulmonary syndrome. So toxo and strongy are parasites which potentially more commonly cause extrapulmonary, but in rare causes can cause pulmonary manifestations. Let's come back to fungal now. So somebody said crypto. Any other fungal infections?
Aspergillus.
Okay.
Histoplasmosis.
Aspergillus is more common in neutropenia per se and bone marrow transplant, not per se in cellular immunodeficiencies, but can still something to put on the differential. Depending on where you are. So if you're what if you're in Ohio?
Histoplasma.
Yeah. What if you're in Arizona?
Coccidioides.
All right. So on and so forth. All right. So we have a pretty good differential here. I'll stop sharing my screen now. Let's go to the further, or actually let's talk about a little bit about workup. So what preliminary workup would you get in this patient?
Chest X-ray.
Great. What else?
A blood gas.
What kind of blood gas?
I mean, I would just get a VBG to start.
An ABG would be more useful.
Oh, yeah, never mind. ABG for.
In a patient whom you're suspecting for PCP, it's important to get an ABG because it has diagnostic implications. You have to calculate the AA gradient and decide whether this patient also needs steroids or not. What else?
CD4, viral load.
All right, all of that will take time. So you're in the ED right now. Basic workup first, right? You want to make sure the patient doesn't have neutropenia. You can have this patient might need neutropenic coverage cefepime as well, because you can have bone marrow suppression in patients with advanced HIV. So you'll order the basic stuff. What else?
LDH.
All right. What will the LDH help you with?
Malignancy.
PCP.
I'm sorry?
If you think about lymphoma could be high.
Okay, so it's very non-specific. It can people usually order it for PCP, but the point here is that it's non-specific, so it won't be diagnostic. I see in the chat COVID, correct? Obviously.
Yeah, we can send respiratory culture by fire, MRSA.
And Legionella antigen.
Good, Legionella. Don't forget Legionella. So let's talk a little bit about Legionella. How do you diagnose Legionella?
Urinary antigen or in the sputum?
What else?
Or respiratory culture.
Good. And so the point here is urinary. It has Legionella has a few serotypes. So it has A, C, W, and I think Y. It has 4 or 5 subtypes. The antigen doesn't cover all subtypes. So if you have a higher index of suspicion for Legionella, you should always get a Legionella sputum culture. And bonus point. So who can tell me which agar you send? It's not a regular medium, right? For Legionella.
Is it the chocolate agar? Red blood agar?
It's something similar to charcoal. It's
charcoal.
Buffered charcoal yeast extract. Not important. All right, we have a preliminary workup. All right, let's start. Yoni, you can start sharing your screen.
Good. Okay, so back to the ED. These are the basic labs. White count of 3.4, neutrophil 64%, lymph 18.9, eosinophils 11%, hemoglobin 10.9, platelets 309, and his chemistries look okay. This is the chest X-ray we got.
Amazing.
Who's going to read it out?
Who wants to read it out?
I mean, we don't have to do it fully systematically. Any obvious findings you see, just shout it out.
A little bit of prominence of perihilar shadows, opacity, sorry.
All right. Yoni, you want to point out?
Is there? Okay.
Sorry about that. So as you can see, I highlighted some of the areas. It was read as patchy, rounded, hazy nodules scattered throughout the lungs, ranging in size from 3 millimeters to 1.7, with indistinct edges. And the impression was innumerable indistinct parenchymal nodules of varying sizes.
Oh, no worries.
In the emergency department, 3 blood cultures were drawn, and patient was started on broad spectrum antibiotics of Avanc and cefepime. So based on this new data, does anybody have a new differential diagnosis and anything else we could do for the workup?
Yeah. Anything which becomes more or less likely?
Mets to lungs would probably be higher.
Okay, so that's one differential for these multifocal nodular lesions. But in this patient who has history of IV drug use, is there any other thing which can cause these multifocal opacities?
Like
Maybe
infective
septic
endocarditis.
Septic emboli.
Good, exactly. So septic pulmonary emboli in a patient with history of IV drug use with infective endocarditis. So what else would you like to do now?
Echo.
Okay. Yeah, I see somebody said CT chest. I think that's fair. Anybody with any other tests they would like to get?
We sent cultures, right?
Yeah.
Yep.
Last slide was just they sent 3 sets of blood cultures and started broad spectrum.
Aspergillosis workup. He has eosinophilia as well.
Good. So what would you work up for aspergillosis?
IgE, skin antigen testing.
Okay,
And histoplasma antigen.
So chronic pulmonary aspergillosis, you would do all of those things. But if you have a patient with whom you think has acute disseminated aspergillosis, specifically in this patient, is there anything else? Good, Carlos says galactomannan, but basic thing you would look for in pulmonary aspergillosis is number 1, you would look at the CT to see the node appearance, because in aspergillosis you'll see ground glass, you'll see nodules with clearing around them or like some haziness around them. The other thing is you would do a fungal workup with galactomannan, and you would also send fungal blood cultures. All right. Let's go ahead.
Okay, so before we get to the workup of differentials, let's just talk about pulmonary manifestations of HIV. So respiratory symptoms are a frequent complaint among HIV-infected individuals and increasingly frequent as CD4 counts decline. This we know. It may result from a wide spectrum of pulmonary illnesses that include both HIV and non-HIV related conditions. In our case, at this point, the driving diagnosis was endocarditis. And then, like we mentioned before, HIV-related conditions could include both OIs and neoplasms. So the infections, we have bacteria, mycobacteria, fungi, viruses, parasites. For neoplasm, non-Hodgkin lymphoma, Kaposi, and bronchogenic carcinoma. They're especially at high risk if they're smokers, and other respiratory illnesses, including upper respiratory infection, pneumonitis, COPD, illicit drug use lung disease, and medication-induced lung disease, all of which we touched on. So further labs that were gotten was the CD4 count came back as 21, and the CD4 count percentage of 3, and a viral load of almost 1 million. His troponin was negative, albumin 2.7, the UA was also negative. So just quickly, for the CD4 count, that's probably one of the more important lab values that you want to know in an HIV patient with pulmonary manifestations. With any CD4 count, you have upper respiratory infection, bronchitis, TB, and non-Hodgkin lymphoma. Less than 500 bacterial pneumonia, and these tend to be recurrent. At a certain point, if they have more than 2 in 12 months, it's considered in some areas a opportunistic infection, like an AIDS-defining illness. Less than 200, you're looking at PCP, Cryptococcus neoformans, bacterial pneumonia of bacteremia and sepsis. So if they're less than 200, you want to make sure you get blood cultures. Less than 100, toxoplasma pneumonitis. The other bacterial pneumonia is like gram-negative bacilla and staph, as well as Staph aureus. Less than 50, now we're talking about the fungals, as well as CMV and MAC. So while waiting all this further workup, the patient was switched to vanc and ceftriaxone and started on Bactrim. We'll go to his CT lung findings. So this was a CT. So it's quite notable for many, many nodules. And the read was numerous, approximately 30 solid pulmonary nodules with surrounding ground glass opacities measuring up to 2.1 centimeters. At this point, still the driving diagnosis was endocarditis. So the next thing we do is we get an echo, a TTE, which showed normal ejection fraction and did not show any vegetations. And then you have to pursue a TEE because the suspicion was very high. And the TEE also did not show any valvular vegetations. Does anybody want to think what we could do next?
I think next.
Actually, you know what? I'll touch base on it. We'll get the infectious workup back.
Yeah.
So this is the infectious workup that came back. So we have the quantiferon that was negative, coccidios, antibodies with reflux that was negative, cryptococcal antigen that was negative. The CMV IgG was one of the few things that was elevated, and this was actually considered very elevated at 10. The normal range is next to it, up to 0.59. Varicella zoster was elevated at 1,622. Syphilis serology, it was reactive, but we didn't have the final ratio didn't result at the time, but we thought it was just related to his prior syphilis. His toxoplasma antibodies came back negative, aspergillus, galactomannan was negative, fungitol negative, COVID negative. The blood cultures, negative growth times 5 days. Respiratory cultures also negative growth, and culture for the AFB was negative times 3. Now the CMV wasn't pursued further because he didn't really have any of the typical rashes associated with CMV, and he also didn't have any of the, he didn't really have any like symptoms otherwise consistent with CMV. Does anybody know what we would do next?
I think we're just left with like bronchoscopy and getting a biopsy, or at least a skin biopsy from the lesions to give us an idea about what's going on.
Very good. So actually the next step was a bronchoscopy. And the main reason, when I was speaking to the pulmonologist, the main reason we got a bronchoscopy is strictly to just rule out PCP. So when you do the respiratory cultures for PCP, this was actually a study that was done at St. Luke's, that the respiratory cultures only pick it up about 45% of the time. And when you do a bronchi-alveolar lavage, it picks up PCP about 95% of the time. So for the bronchi-alveolar lavage, benign bronchial cells and pulmonary macrophages was negative for malignant cells. Culture fungus was negative, PCP was negative, and the AFB was negative once again. However, when they went in with the bronch, this was one of the things that was noticed, and this will give us our final diagnosis. So this was a patchy erythematous mucosa that was seen. In this context, it was fitting for pulmonary Kaposi sarcoma. So just briefly about pulmonary Kaposi sarcoma. So as you know, Kaposi sarcoma, low-grade vascular tumor that's associated with herpes virus 8. Patients with pulmonary Kaposi can present with shortness of breath, fever, cough, hemoptysis, or chest pains. Patients are usually symptomatic, although occasionally Kaposi sarcoma could be found incidentally on imaging. And Kaposi sarcoma may involve the length parenchyma, bronchial or pleural surfaces. In fact, the majority of the time when they went in with the bronch, they didn't see any lesions apart from this one that I just showed. The rest we suspect was all in the parenchyma of the lung. When you get a chest x-ray, it usually shows ill-defined nodules. Diagnosis is often clinical. It's typically based on the presence of mucocutaneous disease, which this patient did not have, chest radiography, and as well as endobronchial lesions characteristic of Kaposi. CT scans, we talked, it shows, usually nodules that are greater than 1 centimeter in diameter. And usually antiretroviral therapy is usually sufficient for treatment. And sometimes chemotherapy might be added if you don't see a response to the antiretroviral therapy. So back to our patient. The patient was started on Biktarvy. He was discharged and followed up with pulmonary clinic. He reported improving symptoms. However, he never followed up for his repeat chest CT imaging. So the purpose of the presentation wasn't so much about this diagnosis of Kaposi lung, but I think it was more about the general approach to pulmonary manifestations in patients with HIV, just because we have so many that come to us that just having a simple approach is very helpful. So I divided it to 3 things that you should pay attention for. So the clinical history and physical, like every other diagnosis, CD4 count, and chest x-ray. Sometimes you might not have the CD4 count. You can ask the patient if they're aware of their CD4 count, or you can gauge based on their clinical history and physical if they're in fact very immunocompromised or not. One thing to note is they had this big study. It was called the Pulmonary Complications of HIV Infection Study. It was a large prospective observation of over 1,000 HIV patients. And that demonstrated that upper respiratory tract infections such as sinusitis, pharyngitis, and acute bronchitis were more commonly the cause of respiratory symptoms than PCP, bacterial pneumonia, TB, pulmonary Kaposi, all combined. So if you're like in an outpatient setting and somebody, an HIV patient comes to you and have some sort of pulmonary symptoms, your first thought should be more of these common, what's common is Anga described. So some keys that you could think of in the history and physical. In many clinical settings, if they have like more severe pulmonary symptoms, you want to differentiate between pneumonia and PCP. Those are going to be the big things you want to differentiate on your history and physical. For PCP, you'll usually have non-productive cough. For bacterial pneumonia, you'll have productive purulent cough. The symptom duration for PCP tends to be weeks, and for bacterial pneumonia, it's usually 3 to 5 days. And actually, interestingly enough, in PCP, 50% of the patients will have a clear lung exam, while in bacterial pneumonia, they usually have focal lung findings. You want to ask about the transmission category and habits. For HIV patients that are also IVD drug users, they're more likely to have bacterial pneumonia and TB, or like HIV non-related endocarditis. If it's MSM patients, Kaposi sarcoma is probably most of the time, not probably, but almost exclusively found in MSM patients. And travel and residence, if you're looking for endemic fungi, you can ask about their geographic regions, and as well as immigration, if they're from Asia or Latin America, homelessness, or incarceration, that will also lead you towards a sort of a TB differential. Like we mentioned before, the CD4 count is very important. You can quickly glance at it. I'll move on though. And lastly, the chest x-ray. Those are the 3 things we want to look at. So the chest x-ray, if it's a normal radiographic pattern, you could think early PCP. Diffuse interstitial infiltrate, you could also think PCP, TB, viral, disseminated fungi, or Kaposi sarcoma. For focal consolidation or masses, you want to think bacterial or fungal, TB or Kaposi sarcoma. Cavitary lesions, you're thinking about TB, aspergillus, fungal. And in pleural fusion, you could think about TB, bacterial or fungal pneumonia, Kaposi, or lymphoma. So let's just go over 3 quick cases. So the first one is an HIV-infected patient, CD4 count over 200, and then any abnormal chest radiograph. What is your differential? And people can just sort of, say it out loud.
Yeah.
Bacterial pneumonia.
Good.
Good. What else?
Bacterial, viral.
Good.
You can go ahead.
All right. Basic differential, bacterial pneumonia, TB, and non-Hodgkin's lymphoma. I'll just remind you of the CD4 counts. Once again, you can get the less than 500, you're talking about already bacterial pneumonia, and then other mycobacterial pneumonias. Case number 2, HIV infected patient, CD4 count less than 200, and this time you have a chest radiograph with a focal opacity.
Bacterial pneumonia.
Very good. Anything else? Bacterial pneumonia, and at this time you also want to be alert for bacteria, bacteremia or sepsis, TB, fungal pneumonia, non-Hodgkin lymphoma, and PCP. And lastly, HIV infected patient, CD4 count less than 200, with a chest radiograph with diffuse opacities. So remember our last one had focal opacities, this time it has diffuse opacities. I'll help you out.
A lot of it is basically the same. So you just, some things go up or down on the differential, but they stay on the list.
It's the same, exactly. So PCP, bacterial pneumonia, TB, fungal pneumonia, Kaposi's is now on the differential, CMV as well. So just quickly, this is something that we always come across, is do you continue with their antiretroviral therapy? So if they're naive patients, they've never been on antiretroviral therapy, you should initiate them within 2 weeks of infection treatment. So early administration is associated with iris, but later ones you risk advancing immunosuppression and mortality. A recent clinical trial showed that early initiation within 14 days reduced deaths or AIDS progression by 50% compared to starting after infection treated. And if they're already receiving antiretroviral therapy, they should be continued on it throughout the infection treatment. And if you notice that you get a CD4 count and the CD4 response is suboptimal, you should modify the regimen that they're on. And that's it. Thank you, everybody.
Yeah. A couple of points. So like we said, PCP, it's one of the great masqueraders. You can never have an exam finding, an imaging study, or anything in the picture completely rule it out, because it can manifest on the X-ray with lots of manifestations with focal consolidation, diffuse ground glass. Even if you have an AIDS patient who comes in with a pneumothorax, the first thing you should think about is PCP. The other thing is common things common. So you should always think about bacterial pneumonia, flu, COVID before you start thinking of going down the route of giving patients treatment for PCP, because the medication, if you're giving bacterial, that's extremely, extremely toxic. So always first rule out common things common. Any questions?
I would just make a few comments. For me, this patient looks really like the patients that we used to see back in the day, right? It's a patient with advanced stage of medication. And to me, it's interesting that these patients with HIV really, are very different from all other patients that we see in medicine, in the sense that normally we want to have one diagnosis that explains all the symptoms, all the findings that we have in a single patient. In this case, we had this guy coming in with low CD4, with something going on, and then we find these skin lesions. So in a non-HIV patient, that would, if you find the Kaposi, you would think that everything else is Kaposi. And that's the case with this guy. It ended up being all Kaposi. However, in HIV patients, it's not uncommon that you will find 2 or 3 different processes, all severe, happening at the same time. So the fact that we had found the Kaposi on his skin didn't necessarily mean that he would have Kaposi on his lungs. It could have been anything else, and I think it was very appropriate for everyone to consider a right-sided endocarditis, but it could have very well been something else. That's what differentiates really these patients with HIV from non-HIV patients. And then the other comment I had is related to the chest X-ray. That when we saw the chest X-ray, people mentioned right-sided endocarditis. And yes, it's the right thought process, but in clinical practice, normally The chest X-ray in patients with the right-side endocarditis who are sending out emboli to the lung, more often than not, the chest X-ray would be normal. I'm not saying that it cannot give you the lesions that we saw in this patient, but it's not common, and particularly not nodules. Normally, when you have a right-side endocarditis giving you emboli, that's going to be picked up on a CAT scan a lot more often than on a chest X-ray. So even though it made everyone think of right-side endocarditis, like there was a right thought process, it is unlikely that a right-side endocarditis will give you this kind of chest X-ray. This chest X-ray was really speaking of some of the process going on, at least based on the image. You know, it was mostly nodules. I think that's all, you know, that I have to comment. Thank you. It was an interesting case and a great discussion, guys.
Yeah, the only extra comment I would have is, you know, that one comment you said where the CD4 count being suboptimal, that would make you adjust your ART. That's not really going to be the thing that's going to make you adjust your ART. It's really going to be your viral load, your resistance, and your CD4 count could take months to years to really rebound. And that's not really going to tell you whether your medications are working or not.
Okay.
And I think it's also useless getting a CMV and a varicella IgG, because that's not going to help you either way. If it was negative, who cares? If it's positive, who cares? We're just wasting money.
Good point. So IgG is, as we know, it's not a marker for most diseases. I think there's almost next to no utility. The only utility of an IgG would be in patients with toxo who are pregnant, because that gives you history of exposure. All right. Thank you, Yoni. Great case. Thank you, everybody. We call it a day. All right. Bye.
Thank you.